This morning, we will be talking about breast cancer index and its impact on women that are battling breast cancer, those women that have hormone receptor positive breast cancer, and how precisely we can be in determining which will benefit most. We have 3 special guests today. The evening will be moderated by Linda Moores out of the Arizona Blood and Cancer Specialists. And our panelists today will be fellow NPs of yours, Marla Sustin at Seidman Cancer Center and Mayra Lima out of the University of Miami. And so without any further ado or delay, I'm going to introduce Linda Moores.
Good morning. Thank you for coming so early. So it's my pleasure. I don't know how many of you guys do breast. I'm in a mostly breast clinic, about 80%. I've been in oncology 26 years. So some of the things that I think we all experience will be shared experiences. So we're going to talk about extended endocrine therapy and how do we make that next decision? How does that work for our patients? So we all worry about the dreaded triple negatives, right? You know, you cure them, they die otherwise. But don't forget that our hormone positive patients, about half of them will develop a recurrence between years 5 and 10. So they have a much longer story than those triple negatives do early. And despite that, we know in the clinical trials about 3 to 5% of the patients benefit from extended endocrine therapy. And we're going to look at the clinical trials a little bit, but how do you pick those people? How do we select them? So if benefit is small, then we start looking at, well, at what cost do we ask these women to stay on treatment for 10 years? So we certainly have bone toxicity with tamoxifen. We see endometrial and PE. And then heart disease, we're having more and more concern about the AIs and how they correlate with lipids. And then tolerability, the things that drag us down in clinic, right? So I worked with a male physician for a long time, and we shared a schedule. And periodically, he would get kicked out of the room and say, "She only wants to see you." Well, you know what that was about. That was about sexual dysfunction, about vaginal dryness. So these are huge issues that our patients struggle with. And this mild to moderate cognitive impairment, I didn't believe in. But it is real. I mean, these patients, especially my older patients, really can struggle with these things. So 26 years in oncology, I grew up pre-oncotype. Okay, I don't work for those people, but I was an early adopter. And this is how we made decisions. We used adjuvant online, right? And it was all about how big is the tumor, how high is the grade, were they node positive? You know, we looked at all these things, and they're still prognostic, don't get me wrong. But back then, we didn't even have Oncotype to help us decide. Everybody got chemo, right? Do you remember those days? So 1 centimeter node negative, they got 4 cycles of standard AC, which now horrifies me, right? Because a lot of those people really could have had much better benefit. So all of those things are prognostic, but none of those are predictive for benefit for extended endocrine therapy, okay? So that's where BCI really fills that void. And we get 2 pieces of information. So when I talk to my patients about it, I tell them you get this new prognosis. It'll give us an actual percentage of what your risk of developing a recurrence is. And then if you have some risk, it'll be predictive. You get a very clear piece of information. You're either a yes or you're a no as to whether or not you benefit from extended endocrine therapy, and that whether or not it makes it worthwhile to struggle with those AEs and the side effects that we see. So if you've not used this before, this is what a report typically looks like. So this patient had an 8% risk, and they're a yes. And when this slide was made, we were giving you an average, we were giving you the full data. So it's a 58 to a 71% risk reduction. Now they're averaging it. So you get, to me, it's a little cleaner report. You get a single percentage. So for instance, 10% drops to 3.5. So it's a pretty significant benefit if you're a yes. Down in the bottom is the dreaded no, right? So if they're going to have risk, we all want benefit, right? So we're going to talk about that as well. How do we handle those patients? So it's now in guidelines. So not only part of ASCO, but also part of NCCN guidelines. So I think that gives BCI more credibility. It certainly is helping us with payers. But my patients also want to know that we know what we're talking about when we make these recommendations, right? So ASCO is consistent with what Biotheranostics recommends. So it's up to 3 positive nodes. So don't be afraid to order it on node positive, and up to a T3. And they agree with the data. You could have had tamoxifen, an AI, or a sequence of them. And also very strongly that the other tools in our toolbox are great for prognosis, but they're not predictive for benefit from extended endocrine therapy. NCCN even went a little bit further and said, listen, if they're a yes, they benefit. So you should be offering this. And if they're a no, they have no benefit from extended endocrine therapy despite our angst. So here are the tools that NCCN recommends and recognizes for all the things that we've got in our toolbox, right? So I'm a big Oncotype user, and all of these are prognostic, right? Oncotype is predictive for benefit from chemotherapy, but none of the rest of them are predictive for the next question, which is what do we do at year 5? Only BCI is actually predictive for that information. So how do we rely on this? So we've got all these clinical trials. So the original one was Stockholm, which was the proof of concept, and this was back when people didn't actually get anything. They just had their surgery, maybe radiation, and off they went. So this was 600 patients that were randomized to tamoxifen or nothing, and those that were a yes had a 65% reduction. And you can see across these, you've got anywhere from 58 to 71%. And a couple things that give us good confidence, TransAtom was an all-node positive study. So these were not little itty-bitty tumors that were all node negative. These were, I think, the patients that we see every day. So lots of data, over 4,500 patients. So there's 2 issues in my mind when I start looking at these patients. And the first one we're going to talk about is how do we avoid overtreating them? You know, that patient that keeps you up in the middle of the night, they had 3 positive nodes. Maybe their oncotype was low, so they didn't get chemotherapy. And here you are at year 5, not wanting to overtreat them, but you're anxious, right? They had 3 positive nodes. It's freaking you out. So here's a case, 54-year-old, 2 positive nodes, keeping me awake at night, small tumor, grade 2, strongly ER positive, but PR negative. That always bothers me a little bit as I think back about my ClinPath upbringing. And they're not happy, right? So they're primed. I want to get off this drug, right? So they've got joint pain, mood swings. So Marla, what do you think about if this is a patient in your clinic?
This is definitely an ideal patient for breast cancer index because we've got positive lymph nodes. We've got an over 1 centimeter tumor, grade 2, and we just don't know if she's going to benefit or not. So this is someone around 4 to 5 years that I would recommend breast cancer index testing for.
Marla, what about you? Mayra, you couldn't have asked that they got me 2 people that have almost exactly the same name. Mayra, so what?
M&M.
M&M, there you go. Mayra, what about you? Do you see patients? Is this somebody you'd be comfortable ordering a test on with 2 positive nodes?
Most definitely. You do not want to overtreat. And this is a patient you want to have clear answers back, and that's what the BCI gives you.
Right. I agree. So we ordered the test, and oh my, 1.9%. You can't hardly ask for a better result with no benefit. And this patient was actually thrilled that they didn't need to stay on treatment because, again, joint pain and mood swings. So BCI, despite our biases where on ClinPath, they have high-risk features. So node positive, maybe a high grade, maybe they're not strongly ER/PR positive. They fit into that algorithm that we've all been raised in. But yet BCI identifies that only about 22% have benefit versus the rest of them. So this should help us with good confidence in those node positive studies to not overtreat our patients. This comes out of the IDEAL study where they were looking at 7.5 versus 10 years. So I think we've all heard some of that data where we thought they were the same. So these were high-risk ClinPath features, yet they were BCI no's, and they had no benefit whether you gave them 7.5 or 10 years of therapy. So what about the other side of the coin? How do we not undertreat patients? So here's a case, 55-year-old, node negative this time, 1.5 centimeter, moderately differentiated, strongly ER/PR positive, HER2 negative, with a low oncotype score, so no chemotherapy. So Marla, what do you think about on this case?
This one, first of all, when we look at the oncotype score, which Linda had talked about earlier, it really is not predictive for extended benefit with endocrine therapy. I would definitely, again, feel that she would be someone that I would mention breast cancer index to, because we just don't know. Yes, clinically, she looks like she's a low risk. She's node negative, 1.5 centimeters. But it's really good to include the patient, especially with joint decision making, and bring up breast cancer index tests so we'll know exactly what we need to do moving forward after 5 years.
And Mayra?
And all I have to say is that some of those benign looking tumors are in the end not so benign. And so I explained that to the patient and I said, look, this is the data that we have. Let's go forward with this test.
So I think we've all been talking for many years about personalized medicine, and this is somewhat at its finest, where you really can make treatment decisions for these patients where it is individual to them. So this patient was an 8% with benefit. So again, like Mayra said, this looks like kind of a benign breast cancer, kind of a very, very happy breast cancer. They should be good at year 5. So this is that patient that at year 8 or 9 has metastatic disease if they didn't get extended endocrine therapy. So BCI identified about 25% of patients that look good, yet really the biology wasn't quite as good as we thought, and they actually had higher risk. And maybe looking back over the years in my career, I think of patients that should have been good. You know, they were a T1BN0, strongly ER/PR positive. They were actually compliant with their therapy, and they should be good. And then here we are at year 9, and they're on first-line metastatic therapy. So don't not look at your earlier stage patients as well. And then this was the same ideal study looking at patients who had low-risk ClinPath features, yet they benefited from a full 10 years of therapy. And the 10 years of therapy with BCI overrode that 7.5. So if they stopped at 7.5, their risk increased because they were BCI, yes. So they benefited from full 10 years of therapy. And the SALSA clinical trial, you may be a little bit familiar with that as well, was that 7 versus 10, that they were equal, did not include BCI. So BCI, that genomic profiling, really gives us more detail about our patient's tumor. So not surprising if they don't get everything that they need, then they've got an increased risk of recurrence. So Marla, I think we talked about that last night a little bit about patients that don't complete their therapy.
Right. And as with everybody we know, when you're prescribed a therapy and you don't complete it, obviously you're not going to get the full benefit from that. So that's something we really talk about, that especially with breast cancer index, it's based on, is 5 years enough, or is 10 years what you need?
Yeah, Mayra.
Yes, and the same opinion here. The patients need the encouragement to continue therapy and not drop it. So giving them the data and now, presenting them that we have 2 big guidelines supporting it, NCCN and ASCO, helps a lot.
So Biotheranostics was nice enough, with me being a heavy utilizer of Oncotype, they actually did a study. And looking at them head-to-head in the trans-ATAC cohort, in the first 5 years, they both fared very, very well. But you can see on the top, the p-value is only statistically significant for predicting extended endocrine therapy when you use BCI. Oncotype's really not designed to do that. It's a, does chemotherapy benefit this patient? So BCI re-stratifies patients that were Oncotype low about a fourth of the time. And I've certainly seen that in my clinic. I've had some resistance from the physicians I've worked with where they're like, nah, they had a 6. So they're good, right? Well, they didn't need chemo. Okay, so we agree on that. But what if they have a high recurrence score and they benefit? We're missing an opportunity to cure those patients. So apparently 40%, and let me just be clear, 40% of your patients aren't compliant, okay? My patients, oh, they're amazing. So they take their letrozole every day at exactly the same time. They're never late for an appointment. They never miss an appointment. They never are the patient that you get that fax from the pharmacy saying your patient maybe is non-compliant because they haven't filled their drug in a while, right? So my patients are amazing, okay? I'm so sorry for you guys. But apparently 40% of patients in this survey were non-compliant, even with the recommendation for extended endocrine therapy. And Marla, what is your experience? Are your patients part of the 40%? Are they perfect?
No, they're perfect, just like yours. No. You know, we do see this. We get the letters from the insurance company. Someone hasn't refilled in a while. And people are always stunned when I say, are you still taking your letrozole? And they look at me like, of course. And I say, ask that, because many of the times I get the answer, well, no. So they kind of just take their vacations and things from it.
So Mayra, what kind of things do you see patients tell you as to why they're not taking their drug?
Oh, I'm going on a vacation, or I forgot it during the vacation. That's the only time I missed it. So I smile and I said, oh, okay, but you have to be compliant. So reinforcement, again, is the key word in the clinic and by all of you. That's the important part.
And again, the side effects are really what, and I'm sure all of you could agree, yes, you have that head shaking, yes. They're not easy drugs for most women. The few that we get that have no side effects are so wonderful, but that's not the majority. And they're tough on a lot of women, and we really have to work to get them through and keep them compliant.
So I grew up in the relative dose intensity era for chemotherapy, where you plan to give this, but they had a dose delay and they had a dose reduction. And so that RDI gets down. And as that gets down and gets lower, the risk of recurrence really goes up. And this holds out true also for our endocrine therapy. When you say you're going to take 10 years of letrozole and they really kind of sort of don't exactly do that, maybe they get 9 years, even that, their benefit really falls off and their outcome is not as good. What I have really liked about BCI, honestly, is the same thing I like about Oncotype. It's somewhat taken the monkey off my back. We look at the data and say, hey, look, this says, I know you're all in and you would take chemotherapy if you had to, but your score was 6, so you don't need chemotherapy. And now you have BCI and it says you benefit, and you benefit from 10 full years. And this is your risk reduction, and this would be your remaining number at the end of 10 years. Patients like to partner with us. I love to teach my patients so that they understand as much as I think they can comprehend, some more than others, obviously. But I think it really has improved compliance. Sometimes I get patients that say, I know I benefit, but I'm not going to do it anyway. But they're informed then, and they can really partner with us. And I think the impact on the relationship and on our patients is pretty significant. So I think it's just human nature. Somewhat in my brain, I play this game when I order Oncotype. I play the game when I order BCI. I bet the number's going to be this. Just because I've been in oncology long enough, you're looking at it going, I bet I'm right. So about 40% of the time, it changes my mind because it's different. It's not ClinPath. It's independent of Oncotype and MammaPrint and EndoPredict. It's different. So we're getting a different set of data. So here are the indications, okay? Don't think it's just for our postmenopausal patients. Don't think it's just node negative. So you've got a T3 with 3 nodes. You're good. It's approved for that, and there's lots of data for it. They can be HER2/neu positive. Okay, I think a lot of people don't think about that. They don't have to be PR positive. They can have had chemo or not. They do have to be disease-free. So this is not a metastatic study, okay? And then ductal or lobular. So the 3 things that aren't included are T4s, so skin or chest wall involvement, more than 3 nodes, we just don't have enough data, and then the poor guys are left out because they're 1% of our patients. We just don't have enough data. Those are the only 3 things that are excluded. So at a JADPRO meeting, there was a survey and said about 76% of patients, APPs, would order BCI on those eligible patients. I think after today and this amazing discussion, that'll be better, right? I mean, this is a better group, okay? I thought it was interesting. I'm only going to order it on people with side effects. Or do we hate those people? I mean, don't we want everybody to have that information? And then patients who are clinically low risk. I'm not comfortable with node positive. Well, get comfortable. We have good data. All of those studies had node positive patients in it. Transatom was 100% node positive. So get comfortable. So Marla,
Yes.
who are you ordering BCI for? And then how do you make sure every eligible patient is given the option for testing?
Well, actually, what I do is I start out at the beginning. When I see someone and we're doing an end of treatment summary, or if I see them maybe 2 years, 3 years in, I plant the seed. And what I say to them is, I'm going to talk to you about a test in the future that's not done on you. It's actually done on your tumor. And it'll tell us if you're going to need to stay 5 years versus 10 years. Now, what's funny is we talked about Oncotype. A lot of patients will say to me, I already had that test. And they're referring to Oncotype. So I explain the difference to them. And so it's usually early on. I don't go into it a lot. And then around year 4 is then we make the decision I present it to them. And ultimately, it's a patient's decision. But most women, once offered it, do want to have it done.
So what do you do to help being sure that you're getting everybody who's eligible? Do you have a tip or something to how do you capture people?
I capture them by actually keeping, and most of you probably do have an oncology history. I see what date they were diagnosed. Well, more than that, when they started one of the when they started their endocrine therapy. So based on that date is when I present about 4 years later, 4.5, depending on how their appointment falls, to review that with them and see if that's what they would like to have moving forward, to give them that absolute yes or no if they would benefit.
So Mayra, we were talking last night, and you had a little different approach in your EMR on how you capture people and who you order it for.
Yes, I have a treatment table, and the treatment table tells me when did this happen. Like, for example, chemotherapy, when did the surgery happen, when did they start the endocrine therapy. And then I have a stop date, that's blank, until we decide when that's going to happen. And as I see the patients, I look at that date of start, figure out the year 3, year 4, and depends on the patient itself, how much difficulty being compliant they have, and, bring the subject of BCI to, again, do several things for me, or for the patient, to encourage them if they, are going to have a low, and also to encourage them if, to be compliant if they have a high and they need to be on it for 10 years. So that's the point where I do it.
So I do mine at the 4.5-year visit. I'm very fortunate. I work with a single physician, so it's just 2 of us managing all the patients versus 10 or 12. I know some of you are in different situations. And so our agreement is to be sure at that 4.5-year visit that we've gone back and we've looked at our table or our history when they first started their endocrine therapy, thinking that this is probably the time, and usually we order it then. And that helps us capture everybody who is eligible. So that you can start the conversation anytime. I don't usually see patients on their first visit, but oftentimes on their second visit. And I start laying the groundwork because they're already saying, how long do I have to take this drug? And certainly we see a few people that have no side effects, but certainly most of them have got something that's bothersome. Mm-hmm. And then again, in about that 4th year, somewhere in there, we order BCI and we get that individual percentage risk in addition to whether or not they have benefit for a total of 10 years. So we talked a little bit about it, but when do you start? Do you always start in that 4th year? When do you guys start even laying the groundwork that there may be more coming, that 5 years may not be enough?
Well, we talk about very briefly at least what I do in the very beginning, that it's going to tell us. And then when we get closer to that 4 years, and when the patient is comfortable with testing, I don't do the testing early on, usually not till year 4. And then that way we kind of have a plan. That's why we're going to have a plan to know what we're going to do, and then obviously address any of the side effects that come along with extended therapy.
Mayra, is that about what you're doing?
Right. Well, we usually, from the beginning, we give them an idea. We say this is either going to be 5 or 10 years, and we will be confirming that with a test called BCI at about year 3 to 4, depending again on the patient, but mostly at 4, we test, and we then present them with the results.
So this was another survey with JADPRO, again, looking at when your peers were typically discussing it, and most of them were about where we sit in that 5-year mark, some of them a little bit later. And occasionally I'll get a patient from another practice that's in year 7 and has not been tested and is appropriate for testing, and we'll send testing then at that point. So this is that dreaded report. It's an 8%, it's a 10%. Marla had a scarier one, even that, and they're a no. So tell me what that discussion looked like.
Yeah, so this was happened recently. I actually sat on the test for a little bit because I wasn't quite sure. I wanted to make sure when I approached her with this, it went well, and I had recommendations for her. So her overall risk was 48.5%. So that's overall, years, beginning till year 10. Year 5, which she's coming up on, and that's why we did the test, is 17%. So I have a very high risk patient with a no result. All right. So those are the ones that you're like, what do I do? So obviously staying on this, on her regimen of endocrine therapy was not going to help her. So I'm certainly not going to have her continue on. But what we did is we talked about what we could do, right? What is it that she can do to reduce her risk of recurrence? Now, we know in breast cancer, we only do any, scans for symptomology. So we talked about lifestyle changes. We talked about a plant-based diet, exercise, minimal alcohol. And that was a little empowering for her to say, okay, and she lives a pretty healthy lifestyle. So when we ended the conversation, it was actually a positive conversation. We took the time to talk this through, and she did take it better than I thought she would. I had one other one years ago that it was very terrifying for her, but she is still, knock on wood, doing wonderful. So that's what I did. So we kind of took the negative in that she's a high result, would not benefit, and we spun it to say, okay, but this is what we can do to help you reduce your risk.
Most of the time, I must say, the patient really takes it well because they've just have had it with all the side effects. So, and everything that Marla said is what proceeds. We talk about, well, now that you don't have the pill as a backup, this is when we need you to put on your big girl's pants and do all of these things, which are easier said than done, but they are more encouraged to do that because they don't have to deal with the side effects of the either tamoxifen or AI, either one.
Right. So I think we've all been after our patients. We know that weight loss is good for you. We know exercise. But some of my patients at this point are still smoking a pack a day. Maybe we should really, put our nose to the grindstone. And, maybe those 2 glasses of wine every night with dinners, maybe not your best decision. So let's work on some of these other things, because this part of your therapy is done. It's not going to benefit you. And certainly we have the rest of those side effects that we can avoid. So this is almost just like the one you were showing us last night, Mayra. Hers was an 11.1%. Yeah, exactly the same. So we have to get comfortable sitting on the data that says this is their risk. okay? But they don't benefit. So all the bone density issues, all the libido issues, vaginal dryness, the arthralgias, get them off their drug. They're getting zero benefit. This is like giving chemo to an oncotype of 0. They have no benefit despite our discomfort, right? Because we like these people. We want them to do well. So again, this is that concern of over-treatment. I have a node-positive patient. They don't benefit. You know, how do you struggle with that? So Marla, what is your thought process in your conversation?
Well, you know, I was just thinking back to when I first started using Breast Cancer Index many years ago, and I'd be on the phone all the time. I don't understand. This is high risk, and they're not going to benefit. So it was a learning curve for me as well. But I go back to the data. This is what we do, right? We don't make, you know, random decisions. We go back to our data, and the data for Breast Cancer Index is very, very strong. If they're not going to benefit, they won't. If they will benefit, then we know that they are going to get about a 2/3 risk reduction. So if you're comfortable and understand the data, then it's fairly easy to say this is what we're going to do. And sometimes the more challenging is obviously a patient who says, well, I want to stand it anyways. All right. So that could be a challenge. But usually, again, relying on the good data that Breast Cancer Index has makes it easier.
So Mayra, you as well, those node-positive patients, how comfortable are you in saying, okay, if you're a no, we are going to stop you, even though you were node-positive?
Yes, again, this is when you, you explain to the patient the data, and you explain to the patients that we have ASCO and NCCN guidelines now. We also explain to them, this is what you are going to derive the most benefit from at this time, these changes in your life, whether it is, stopping smoking or, exercise, weight that, and also, the AIs and the tamoxifen have an impact on your weight. So, being off of it, we know that now that you don't have it, this is when you're going to have, the best benefit in your efforts.
Right. And so if you ever need to look at the data, your MSL, your reps can get you these individual clinical trials, because TransAtom is really impressive. And it was a tamoxifen 5 or 10 year data. It wasn't even AI. So, and they were all node positive. So how can we, I hate to say spread the word, but it was a struggle when I changed physicians about 4 years ago. My doc retired, we changed practices, and she was a breast cancer, but she did a lot of myeloma. She was a transplant physician, so probably only about 40% of the practice. So I brought my retired physician's practice with me, and so now we're about 80% breast, which I love because myeloma is just not that much fun to treat. And so having that discussion. So what has your experience been with your APPs in the clinic or your physicians in saying there's real data behind this?
Yeah. Well, we've hired a few newer nurse practitioners, and they have a lot of oncology RN experience, and they're often reaching out. Marla, what do I do with this patient? What would you do with this situation? I had one, Robin reached out to me about 2 weeks ago, and I said to her, run BCI. Run BCI. That's going to tell you what you need to know. That's going to tell you your risk of recurrence, and it'll be comfortable for the patient to understand and empowering in a lot of ways to understand the risk and what she needs to do, whether it's stopping the medication at 5 years, pushing through for 10 years. So a lot of education, especially with our younger nurse practitioners.
Guiding and mentoring is very important. And so, I do a lot of preceptorship, and I start, at that level, because since we are in the clinic, we're going to be ordering it. I start the seed, like you said, at that point. So definitely also our ONS meetings, are very important to let them know, where we go from here.
So I think by nature, we're all teachers. I think that's one of the strengths of APPs. And I think in my experience, APPs are much more comfortable leaning on each other versus, if there's a physician in the room, I'm sorry, but versus the docs. I think APPs are a little bit better at that. So here are the guidelines. This is intended to help us make that decision about extended endocrine therapy, those 3 to 5% of patients that benefit. Who are they? Because you don't want to treat 100% of patients just to pull out that 3 to 5. It's like giving chemotherapy before Oncotype. This helps discern who those patients are. It is the test. I mean, it says most commercially available, validated. It is the test. It is the only one in NCCN and ASCO guidelines to help us make this decision about extended endocrine therapy. So we've all got a little story we want to share with you about one of our patients and the BCI result and how it impacted them. So Marla, tell about the one that we talked about last night.
So I was thinking about patients, and this patient always stands out to me. So she's a professional woman. I don't remember, she was in some type of administration, and very fit, very healthy. She was one of those patients that likes minimal intervention, but she was a higher risk patient. She was HER2 positive. She declined chemotherapy. She declined HER2 therapy. So talk about a patient that keeps you up at night. But she did agree to take an anastrozole, I believe she was on. So again, around year 4, we talk about it, and she says, no, I think I'm just going to stand it for 5 years. I'm good. She had no side effects. She's one of those patients that didn't have any problems with it. So after discussion, she agreed to go ahead, and I said, let's just take a look and see what it says. And lo and behold, it came back. Her risk was, moderate, but she did need to continue on. I believe her risk was 13%, so it was a little higher. So called her with the results, and she was, no thanks. All right, I get it. I'm happy with my 87% risk of it not coming back. And she said no, right? So I was really disappointed because she didn't have any side effects. This was not bothering her. And lo and behold, about 2 weeks later, I get a call and say, tell Marla to refill my prescription. I'm going to continue on. And she's doing well today. And it just shows she just needed time. She needed time to think about, well, gosh, my 13% could go down to like 4 to 5%. I'm not having any problems. So I was really happy that she made that decision and just needed some time to mull it over.
And I had a patient who was young, was having a lot of side effects, especially vaginal dryness and issues with intercourse. So luckily, when I say luckily, I'm preempting my story. So she got a low, and when she heard the news that she only had 1 more year to finish, she was very happy, very, very happy, and a different type of person. The other thing is, that we didn't touch on it much, but with all of these medications, there is mood changes, not only a little bit of cognitive changes, but mood changes that sometimes end relationships. So, BCI probably saved her marriage. So,
Put that in your press release.
Yeah, right.
BCI saved my marriage. I love that. I think we take some of that for granted, right? The other thing that you mentioned that I want to touch on is if you ran that test at year 5 and they're a low, they're a no, they still need 5 years of therapy. Mm-hmm. So don't forget that patient needs to understand this assumes 5 years of therapy. You can't stop at 4. It doesn't give you license for that. So I've had 2 in the last couple of months that were Oncotype zeros. They were those T1, one was a T1B, one was a T1C. They're N zeros. They were Oncotype 0. And my physician's like, yeah, do whatever you want to do because you're going to do it anyway, right? I know you speak for these people, so just go ahead and do it. So I did, and they were both high. One was over 11, one was a 9.8 with a yes. So again, remind yourself this is different. Just like you said, the patient said, oh, I've already had that test done, or I had genetic testing done. I've already had that done. Sometimes payers are a little confused. We've already paid for genetic testing. No, you paid for genomic testing to determine chemotherapy. This is now extended endocrine therapy. So be careful, I guess would be my advice to you. This is different information than the other ones, and this is the only test that we have to make that decision between years 5 and 10.
And I just want to say, we practiced yesterday too, and I found it really interesting. I know what my patient's oncotype test is if they had it done. And I don't use that. I never go to that as far as a decision for breast cancer index testing. I make the decision on, as long as there's, enough to test, I don't even consider it. And I guess the reason I know now is because, like Linda alluded to, one is for chemo, one is for extended therapy, but I never take it into consideration when I'm ordering breast cancer index testing.
I don't take it into consideration, but what Linda said was absolutely on target. A lot of confusion as to which one is which. They don't have any clue. They tell you, "Oh, I've already had that test." So then I have to go look if it wasn't documented, in the history of present illness, which I usually try to keep up really good. But if it wasn't documented, I have to go back to see, did she really have it? Because I didn't order it, but maybe another provider did. So yes, just confirm what is it that they're telling you, because most of the time it's not a BCI, it's an oncotype.
All right. Well, thank you for getting up and having breakfast with us early this morning. Thank you so much.